Welcome to Healthy You on the Family Medical Network. Today, we are joined by Dr. Hibbert. Thanks for joining us, Doctor.
Thanks for having me, Henry.
You are an expert on lung cancer at Springfield Hospital. Can you tell us about this disease?
Henry, lung cancer is the most common cancer in the world and the leading cause of cancer-related death in men and women in the U.S. since 1985. The average 5-year survival rate is only 15%.
How many different types of lung cancer are there?
The World Health Organization divides lung neoplasms into 12 types. In medicine, we focus on small cell and non-small cell carcinomas. Non-small cell can be further separated into large cell, squamous cell, and adenocarcinomas. These categories help us determine treatment options and prognosis.
Which of these is the most common and what part of the lung are they found in?
Adenocarcinomas make up 35 to 40% of lung cancers. They are located in the midlung and the periphery. This cancer spreads early to the lymphatics. Squamous cell carcinomas are centrally located and account for 20 to 30% of lung carcinomas. This type metastasizes late and often causes cavitation and obstruction pneumonia. Large cell carcinomas are manifest as large, poorly differentiated peripheral masses. They metastasize early and make up 10 to 15% of lung cancers.
What about small cell carcinomas? I hear they are really bad to have.
You heard correctly, Henry. They are very aggressive and have a high cavitation rate. They have also been linked to a lesion on the short arm of chromosome 3. Small cell carcinomas are centrally located and are associated with early extrathoracic metastasis, including paraneoplastic syndrome.
I think everyone has been told that smoking causes cancer, but how true is this? Are there other risk factors?
Smoking is the predominant risk factor. There is a direct correlation in 90% of lung cancer cases in women and 79% in men. Don't forget about secondhand smoke. If you smoke in the home or in the car, you put those with you at risk. There are also many occupational risk factors. We have all heard about the dangers of asbestos, but exposure to radon, arsenic, chromium, nickel, vinyl chloride, and ionizing radiation can increase your risk of developing lung cancer.
I read somewhere that having a pre-existing lung condition, like COPD, idiopathic pulmonary fibrosis or tuberculosis, also puts you at risk.
That is correct, Henry.
What kind of signs and symptoms do you look for in a patient?
There are many symptoms a person with lung cancer can have. They often present with chest discomfort, cough, difficulty breathing, and hemoptysis. They also notice weight loss, fatigue, fever, anorexia, and difficulty swallowing. Pleural effusions occur in about 10% of patients, along with recurrent pneumonias and localized wheezing. Superior vena cava syndrome is a sign of extrathoracic spread. The SVC becomes obstructed, causing backflow of the venous blood. It is usually caused by a bronchogenic carcinoma or metastasis.
How do you identify superior vena cava syndrome in the clinic?
The patient usually experiences headache, nausea, dizziness, visual changes, syncope, and/or respiratory distress. The physical exam shows distension of thoracic and neck veins, edema of the face and upper extremities, facial plethora, and cyanosis. Additionally, a patient may also present with Horner's syndrome and paraneoplastic syndromes.
So you suspect your patient might have lung cancer. What type of diagnostic tests do you use to confirm it?
Diagnostic imaging is very useful. A CT scan of the chest can be used to evaluate mediastinal and pleural extension. Even better than a CT is a PET scan, which is useful in diagnosing mediastinal and distant metastases in non-small cell cancers. It is also used in pre-surgery staging of this type of cancer. Orthoracotomy is best for tissue diagnosis in early non-small cell carcinoma. It is best to use the least invasive method available when trying to diagnose small cell or metastatic non-small cell carcinomas. Examples of this are flexible fiber optic bronchoscopy, transbronchial needle aspiration, thoracentesis of pleural effusion, and excisional biopsy of accessible node.
You mentioned tumor staging. Can you tell us more about that?
Yes. Non-small cell tumors are staged using the TNM staging system. There are 4 stages. The first stage has no lymph node involvement. Stage 2 involves spreading to ipsilateral bronchopulmonary or hilar lymph nodes. Stage 3 has ipsilateral mediastinal node involvement. In stage 4 there is metastatic disease. Small cell carcinomas are come in 2 stages. Limited stage disease, which is confined to regional lymph nodes and 1 hemothorax, excluding the pleural surfaces. Extensive stage disease involves metastasis beyond ipsilateral hemothorax.
Dr. Hibbert, will you tell us how you treat someone once you have diagnosed and staged their cancer?
Treatment is determined by the cancer's histologic type, its stage, and the results of the patient's lung function tests, which consist of FEV1 and DLCO. We start off with non-pharmacologic therapy, such as nutritional support, avoidance of tobacco and other products harmful to the lungs, and supplemental oxygen. With non-small cell carcinoma that are stage 1, 2 or 3, surgical resection is considered. If the FEV is greater than 1.5 liters, a lobectomy is performed. If FEV is equal to 2, we consider a pneumoectomy. It has been shown that preoperative chemotherapy improves survival, while post-op chemotherapy can eradicate occult metastases. For unresectable non-small cell carcinomas we use radiation alone or in combination with chemotherapy, but the prognosis is poor. For limited-stage small cell, the treatment of choice is thoracic radiotherapy and chemotherapy. For extensive stage, we use combination chemotherapy. Palliative and hospice care is crucial for end-of-life modalities.
What's the prognosis for these types of cancer?
With a resectable non-small cell, 30% of patients survive 5 years. With metastatic disease, palliative care improves survival rate. Small cell cancer is a bad type to get. Patients with limited stage can expect to live 15 months. With extensive disease, it's only 9 months.
Wow. Those are not good odds. How can someone limit their risks?
Don't smoke, and if you do, you need to stop. Go see your primary care provider if you need help quitting.
We are out of time. Thanks for being on our show today.
Thanks for having me, Henry.
A special thanks to Dr. Fish and Mr. Rust for your lectures on lung neoplasms. Join us next time when we learn about Peyronie's disease.